Thank you all for having me here. I'm Marc Rothman. I'm the Chief Medical Officer of the Nursing Center Division at Kindred Healthcare. It is a true honor for me on behalf of all of Kindred's many thousands of employees to be asked to join you today. So thank you very much for that. Dr. Wong, Richard, the minister who just left, and other distinguished guests. In truth, you as a delegation have really seen the best of Kindred Healthcare already, because yesterday you toured several of our facilities and met our leaders here locally. And while our facilities are nice, our people are our greatest asset. And so you really met the best of Kindred Healthcare already. I'm just, I guess, the window dressing afterwards, the short aperitif after the meal. So far there's been a fantastic conversation, and even the slight bit of tension that we generated, which I welcome, I experienced that tension in my own heart because as a geriatrician, a palliative care and hospice physician, and as someone who believes fully in integrated care, which is why I worked at Kaiser Permanente in California for 5 years, part of which is where the term accountable care came out of, and then left to go join the largest provider of post-acute care diversified services in America, which is a very for-profit publicly traded company. I understand that tension in my own heart. But that's where we have to go. We have to marry these conflicting ideologies, perhaps, or not conflicting, but complementary somehow. What I hope to do, and I was going to say that now that I've heard that you have a national single electronic medical record, a pharmacy cloud where all medications can be registered, and you are standing up universal long-term care insurance for the nation, I am wondering if you have anyone from the Department of Immigration that you brought with you, because I'm ready to go. Sign me up for Taiwan. That seems like a dream come true from the geriatric perspective. Thank you. So on the theme of doing things differently, I'm going to give you a brief introduction to Kindred Healthcare. I have to do that. I'll try not to spend too much time on it. I'd like to talk a little bit about the changing face of post-acute and long-term care in America, because those two things are inextricably linked in America, both in terms of payment, in terms of workforce, in terms of physical plant. Those two things have historically gone together, and they're under stress internally, and I think that'll be useful for you to learn from. And then really I want to take you through a little bit about how we're trying to adapt and lead in the integrated world, because things for us are changing. So Kindred Healthcare really is its people first. We employ 63,000 people nationwide. I've been told that we're the 152nd largest employer in the country. We took care of 500,000 people last year, touched 500,000 lives and patients and residents. We do that in over 2,000 locations in almost every state. So we are quite a big endeavor. While we do that, we continue to outperform national benchmarks from a qualitative perspective. On an aggregate level, we always have pockets that are in trouble, of course, but on the aggregate, we outperform benchmarks, including things like hospital-acquired infections, central line infections, most of our nursing home regulatory measures, we are at or better than the national average, et cetera. And we send a lot of patients home. Now, it might look like we only send half the patients home, and that's partly because the long-term and the post-acute are linked. But that is a much larger number than traditionally ever went home from long-term care in America or facility-based long-term care. Our length of stay has consistently gone down over the last 5 to 10 years and continues to do so every year. And we continue to reduce the rehospitalization rates, which I'll show you. And one of the things that we struggle with as a company, and which individual owners of a single facility, perhaps, who are not corporate, struggle with, is that means doing the right thing. Sending people home sooner, not having them bounce back to the hospital, all is the right thing. Under our system of fee-for-service medicine, it's not rewarded at all. Right? There's no incentive de novo to do that. but we know that we have to do this for the patients and for the future. The unsustainability issue looms, I think, for us as well. So here's an example. We've been reducing the recidivism to the acute care hospital for 5 to 6 years. And we've done that just from our own initiatives. We hope that that continues. I think that there is a large amount of effort going into reducing rehospitalizations. There's no question that for the patient, for the N of 1, going back to the hospital is the wrong thing. If it happens to you, it's the wrong thing. At some point, that decrease will flatten out. I don't know what that number is. For groups like Kindred, who take very, very complex patients, I wish we knew what the floor was. I wish we had a target. I think we can get to somewhere around 10%. I hope we can get lower. How do we do our business? Today, I don't have a pointer, so today, about half of our business comes from our long-term acute care hospitals, which you toured yesterday across the street. About a quarter comes from nursing and rehabilitation centers. About a quarter comes from our rehabilitation services. We are the largest employer of rehabilitation specialists in the country, except for the VA, the government program for veterans. And then a small piece of our business today is what we call care management. And inside of care management is both home health, hospice, as well as what I'll describe to you as what we are trying to build so that we can do the things that Dr. Bieber described. Traditionally, and to the issue about sort of why hospitals, I struggle with that too, why were the hospitals given the reins and the control? How about us? We're big, we take care of lots of people. And part of it has to do with capability. If you want to manage the population, you need the data, and you'll have the data. But in America, not everybody has access to the data. Even University Hospital had to hire a whole team of people to do that, and then take the data from CMS and figure it out. And what we've realized is that organizations that can do that are going to be the ones who can play in the sandbox the best together. So we are building out that capability within our care management division, and I'll try to take you through that in a minute. Where does most of our revenue come from? Half of it comes from Medicare and Medicaid, a quarter from commercial and other business to business. We expect that that will change, and I'll show you that in a minute. Where are we? We are almost everywhere. We have approximately 310 brick and mortar sites of service, like the places you visited yesterday. But then we have another 2,000 places or 1,800 places where our rehabilitation staff either go and do the work on behalf of a hospital, on behalf of another rehabilitation facility that we don't own, a doctor's office with a rehab practice, all kinds of different venues that our rehab therapists go to. And then we have a whole cadre of places that we help manage. We help them manage their services because we have a lot of experience and a lot of expertise doing that. And just like Dr. Bieber said, a lot of the history of the hospitals has been, many of them at one point tried to do a bunch of these other things. Buy a nursing home, buy home health, buy a rehab center. And in the end, it's been very difficult for them. So often they come back to us for assistance because we know how to do it really, really well. What you'll notice is that there are places with circles, and we call those our integrated care markets. And so in order to meet the challenge of what we're talking about today, just like you're talking about when I looked at your map with rural areas and not rural areas, it's very hard to get the integration across the sites of the service, the professionals that you need, the staff that you need, the communication with the patients, the doctors, in more rural areas. And so what we are trying to do is cone down geographically, at least for this part of our development and growth, so that when we build out our care management and try to take care of a population within our system and network with hospital systems like UH, Cleveland Clinic and others, we do that in a place where we have kind of critical mass of stuff, of our Kindred stuff. So for us, that's home health, hospice, nursing home, long-term care, post-acute care, hospital, rehab, etc. And so those are our integrated care markets. And the integrated care market strategy is really designed to try to prepare us for the day when the integration is taken for granted. across lines of service, and then the risk and the payment methodology follows. So 3 components to the integrated care market. Number 1, continue the care. That just means have all the assets in place. So we actually have just undergone a process where we divested ourselves of nearly 120 nursing facilities that were standalone, that were out 3 hours from the nearest other site of service for Kindred, because that's going to be too hard for us to tie together today. So establish the continuum in those markets. Then manage care transitions, and that's our care management capability, which I'll show you in a second. And then finally, once that's done, we need to get a new payment system between us, our partners, those groups that are at risk, because we know where it's going, right? We will not be able to exist in fee-for-service forever, and we're very, very aware of that. We're trying to get ahead of that. What do we expect? We expect that overall quality will improve, value will improve, overall cost will go down, just the way Dr. Bieber said. I'm a firm believer in that. I think that is true. The hospital readmission rate will go down. In the end, we'll probably end up with higher volumes, even though the cost per is less, and then we'll have a larger margin. So what does care management mean for us? So this is the platform that we are trying to use and wrap our brains around to allow us to do what I think you guys are trying to do in Taiwan. But historically, we were just a company with a lot of buildings, and we didn't have these capabilities. So as we have people moving back and forth from the acute care hospital to home, I totally agree with the idea that things should be in the community. Everyone always draws this as a pyramid with the hospital at the top and home at the bottom. And I've been saying for years, I think that's fundamentally wrong. It should be the inverted triangle, right? They start out in the home, and then they access services. Eventually, I think that will, be at least a larger portion than it is today. Right now, everybody goes from home to hospital. And we think of that as a waste of resources, especially for not emergent things. So as people are moving back and forth, what do we need in our own wheelhouse to be able to say to a hospital system, to an insurance company, to a government program, we can manage the population. We can be at risk. We can drive down the cost and increase the value. We need things. We need physicians who are across our sites of service. We can't have physicians who come into one site and then leave. And then we move the patient and another physician comes in, like a mercenary, hit and run and leave, right? We can't have that. And American medicine is struggled with that. And the accountable care organizations, I think back to those comments before, one of the reasons that the hospitals had to be partially in charge is because they're the only ones who could get leverage over the doctors. And in America, that's a very tough battle in America. So we need physicians who are across our sites of service and who understand our mission and are participating. We need care managers, as was discussed, to smooth the transitions between these sites of service, because we know that it's at the point of handoff from one site to the other where at least half of these readmissions occur, missed medications, missed meals, lack of monitoring, etc. We need a lot of IT and information technology. We just need a lot of IT. And I'll show you that. If I can get to the end of the talk, I'll show you some of that. We've done something that I don't think anyone else has done in the post-acute space. We have just stood up our own health information exchange between all our sites of service so that all of them can begin to talk to each other in 2015. And from that health information exchange, communicate with every exchange out there across the country, depending on the maturity of our system and their system and the state. We need the ability to make decisions clinically, quickly around where patients need to go. In America, the decision to discharge a patient from an acute care hospital is made now, and by 1 o'clock, the placement has been made. And there are systems that are coming up and technologies that are disruptive that are going to try to shorten that time to minutes, almost like, what's it called when you reverse bid? When people in industry reverse bid for the contracts, I forget what that, my friend's in business, I forget what that's called. There are technologies that are going to try to connect people who need a hospital discharge with a place for them to go instantly. We need to be able to do this quickly. The old fax, call, fax again, call. ask the family, go tour. So we need the ability to do that quickly. And then we need condition-specific clinical programs, pathways, and outcome measures, just like any good system does, to track our progress. We also need for us, and one of our big initiatives is to try to make some of these outcome measures the same across sites of service, so that if someone asks, how do my patients do at Kindred, even though Kindred might have managed them perhaps to the nursing home for a short period of time, back to home, if they got sick, perhaps even back to the nursing home for a few days, back to home. How did Kindred do? We could say, by this metric and this metric and this metric, this is how you did, and that's the same for all our sites of service. Right now, there's different measures for the hospital, different measures for the nursing home, different measures for home health. The 30-day readmission rates are calculated different. Everything's different. And we're trying to unify that, at least with regards to things like customer service, things like readmissions, adverse events, et cetera. And why are we doing this? We're doing it because our view of the future really is that we are going to move to a risk-based system, right? We've always been here at fee-for-service. We're dabbling in pay-for-performance. We're working with some bundle, some gain sharing perhaps, but eventually there's going to be full risk. That's our assumption. And we have to make sure that we understand the risk going in, not just the other partner understanding the risk and contracting with us. And the underlying reasons for this, I think you saw this yesterday, why do we think our assumptions are partially correct? Because almost 40 or 50% of people from Medicare are discharged from acute care into some kind of post-acute benefit entity, whether that's LTAC, inpatient rehab, skilled nursing, outpatient, home health. These are the percentages of where they go when they're discharged, but if you look out 90 days, people re-engage. So things like home health care. If over half of people who are over 65 are going to use home health care after leaving a hospital, that's where we want to be. So good. Hopefully I didn't spend too much time on Kindred. I want to talk a little bit about the changing face of post-acute and long-term care. I don't want to give an enormous history lesson, but I think it's important as you have the opportunity to design things de novo to sort of see where the conflicts are for us. We have conflicts, internal conflicts. Kindred really grew out of the nursing home and rehab business and the LTAC business, but the nursing home business was very different 15 years ago. It was night and day to what it is today. My own training, it was different. Historically, the nursing home was the patient's home. There was an enormous preponderance of dementia without a lot of all the comorbidities that we know are affecting our populations today. They were on fairly simple medication regimens. Most of my long-term care patients were on 4 medicines, 5 medicines. We focused on custodial care. We were not focused on treatment as much as we are today. The primary care doc from the community came in once a week, twice a month, just like primary care. And there were only a few skilled beds, right? There were only maybe 20 beds for rehab. That's where the skilled word comes from, right? Skilled nursing facility. They didn't have to be skilled. They could just be nursing facilities. You didn't have to have rehab therapists, speech therapists, occupational therapists. You didn't have to manage all that. You could say, no, we just take care of chronically aging people with dementia for the rest of their lives. You didn't have to have skilled. Even the ones with skilled, I worked in the largest nursing facility in Connecticut. There were only 25 skilled beds. The place had 180 beds, but only 25 of them were for post-acute rehab. And discharge to the community was rare. People lived there. What's happened? In the last 15 years or so, when new hospital reimbursement strategies came into play, hospitals began charging patients what we call sicker and quicker. You can find that in lots of articles, right? And they had to go somewhere, and so they came to skilled nursing. And we filled that need. So immediately we had more skilled beds. We have facilities today, almost all of our facilities today are almost half rehab beds for post-acute care and half custodial beds for people to live out their lives in our care. We have many buildings that are 100% skilled. They are essentially rehabilitation facilities. That's it. Some of them don't even accept the payment to take care of patients for the rest of their life. Patients have to leave, or they have to write checks. So that's where our acquisition of rehab care came in. So we acquired rehab care and became that largest provider of rehab services. More frequent admissions. It's not uncommon for our facilities to have 8, 9, 10 admissions a day on a threadbare staff. Lower lengths of stay. Traditionally, nursing homes that did rehab had people for about 20 to 30 days. A lot of people after a hip fracture, et cetera, pneumonia. We have facilities out west where the average length of stay is bordering on 8 days. Still with the same volume of admissions and discharges. But unlike a hospital, it's a challenge for us because we're not really set up to take 8 admissions a day, every day, and discharge that many every day. Now there are specialized units for vent patients. We take patients who have tracheostomies and nocturnal ventilator support in nursing homes that have skilled beds. Wound care, pulmonary care, cardiac care, very, very specialized now. And frequent discharges to the community, like I said. And now, from the post-acute nursing facility perspective, we now need a discharge destination, right? And care is continuing in the home from us. We're not even finishing it now, not at 8 days. So we need a discharge destination, just like the hospital did. So that's our investment at Kindred at Home, which is our home health and hospice business, which I'm told is the 5th largest home health and hospice company in America. I don't know if that's true. I think so. But we view it as being cost effective because even though we apparently are using a larger and larger share of Medicare dollars, compared to the hospital, we are certainly much more cost effective. And we have great outcomes from a rehabilitation standpoint, from a functional standpoint, getting back to independence. The hard part is we're still regulated like a nursing home. And we still care for long-term custodial, Alzheimer's, dementia, very ill, end-of-life patients. And there's a tension there, right? Because we're regulated like a nursing home, we have to provide nursing home care even if you're there for 8 days. And that's complicated. We've had to adapt to a younger, more active clientele with expectations of discharge back to their lifestyle at home. And that's completely different. That's been a hard thing for our workforce. A lot of our workforce chose not to work in a hospital. They're working in a nursing facility. They're excited about geriatrics. They're excited about older adults. They're excited about family connections and getting to know patients. And now they're in a setting where they have younger patients who want nice food, don't like the decor, want to get home as soon as possible. It's tough for the staff. They need a new skill set, right? It can't be a quiet, comfortable place where they get to know you over a long period of time and things will work out. Very different. So our nursing facilities look like this, with rehabilitation gyms that are the size of what would have been 10 rooms. And we have family lounges that look like the lobbies of hotel rooms, because when the family visits, that's what they want to see. This facility has a movie theater, which is small, but it's heavily used, interestingly enough. So that from our perspective is all good. Here's how CMS and the economists look at us. There's been an enormous uptick in Medicare's total and per capita spending since 2000. Right? It makes sense why. They're not in the hospital anymore, but still, these numbers, the graphs that Eric showed, same trajectory. And Medicare's actual dollar spend has doubled since 2001. The top line is the total. The next one down is home health, actually, and then SNFs and long-term care hospitals and inpatient rehab. Skilled nursing is at the top. So skilled nursing and home health is very much on the minds of our friends in Baltimore because of these trends. It's probably on the minds of the financial people at Kindred too. But then when they drill down even further, they find the thing that they like the least, which is variation. Geographic variation in how much money is being spent, for example, on skilled nursing in blue. So at different parts of the country, the post-acute care spending is widely different. And that is a red flag for overuse of services, inefficient use of services, perhaps not a good match of dollars to value. So what does Medicare say? Medicare says for nursing facilities and post-acute care in general, including home health, it's got the fastest increase in healthcare spending. They say the margins are too high. They're concerned over overutilization on one hand. You're using too much therapy. On the other hand, they want high quality. On the other hand, they want people rehabilitated, but they don't want you to use too much therapy. They think that there's an overlap in patients between post-acute care settings, and that is partially true. We have seen that. We have acquired things like long-term acute care hospitals from other companies. We've gone in and we look, and they're SNF patients, at least for us. They're skilled nursing patients by our definition. So there is a little bit of not as appropriate placement in different settings as there needs to be. And there's wide variation. So it's very high on their list for reform. I always have to make a comment about the margins because the margins are from the Medicare perspective, for the skilled side. In reality, the patients that we take care of day after day until the end of their days on the custodial side there's no margin on that, practically. In fact, I paid more for my hotel room last night in Chicago when I failed to get to Cleveland last night. So am I doing okay? I paid the equivalent at my Courtyard Marriott hotel room as some states pay us to take care of a frail elder custodially, which includes meds. Oh, not includes meds, which includes room, board, personal care, recreational services, et cetera. That always shocks me. But on the Medicare side, the payment is very different. So back to that question of, are you going to have two different payments or different payments for each site? And I think you need to think about that, because for us, it really, in full disclosure, leads to a lot of juggling between sources. Not quite robbing Peter to pay Paul, but there's a little bit of that. But we have internal challenges as well. So the clinical competencies of our staff are nothing like what they needed to be 15 years ago. They're much closer to hospital-like staff. So our nurses, our case managers, our rec therapists, our social workers have to be at a completely different level, up to their license, as Eric said. We need to right-size the physician presence and the physician approach, in my personal opinion. We have more doctors coming in to do more medical care, which is good, but there's a balance between too much of a good thing or a disorganized amount of a good thing and the right thing. And we haven't really hit that yet. A lot of post-acute care physicians are trying to get more mature, the way we're trying to get more mature around knowing their population, knowing how much care they're giving, trying to tie it to the value, their actual personal outcomes. They are, to some degree, even further behind, especially if they're independent. We have to meet the needs and expectations of a new set of stakeholders, like the accountable care organization in the neighborhood. They have high expectations. Now that's a good thing. In reality, in the old days, they discharged to us and didn't look back. And now they're discharging to us and looking. So I think that's a good thing, but there's a cultural challenge there, right? We're not used to being watched, and we're being watched today. And then there's this tension that I worry about personally as a geriatrician and as someone who loves long-term and post-acute care. I worry about this sort of balkanization of post-acute and long-term, where there's these post-acute patients that everybody's super interested in, and then there's these long-term care patients that we really have an ethical responsibility and a moral responsibility to care for until the end of their days. And we can't let other people tell us what we need to do for this group while not taking any responsibility for this group. I feel strongly about that. But their acuity and their care needs are totally distinct. They're just completely distinct. The level of interest from physician groups, from hospital networks is completely different. I have doctors who say, I just want to see all those patients who came in from the hospital last night. I'll see them all for 2 weeks, and then if they have to stay in the building, some other doctor can take care of them. I'm not interested in that because it doesn't pay well. And that's just not appropriate. And then the regulatory and reimbursement issues that I was talking about, those two payer sources in the same building, very complicated. And I worry that there's a lot of fracturing there. And as I was saying before, you can't just wish the long-term care needs away. Even the skilled side needs somewhere to discharge to. We have to discharge the patients. We have more people coming from the hospital. We need that opportunity to take care of patients long-term. Sometimes it's in the same building, but if it's not, we need it in a building nearby. We cannot send, in San Francisco, there was such a problem. This is becoming such a problem in San Francisco. some nursing facilities are shutting down. The rest of us are very high acuity. We discharge patients, or try sometimes, to 30 miles away. That is not appropriate for patient choice. It's just not a good way to treat our seniors, and it's not a good way to treat their families. And I worry that this struggle between these two entities that are side by side inside our walls sometimes is causing problems. So let's talk a little bit about what we're doing to adapt. I'm going to talk a little bit about the bundled payment demonstration, which I know you're eager to hear about. I'm going to talk about our transitional care program that helps us manage some of those transitions from setting to setting. Talk a little bit for 1 or 2 seconds just about trying to harvest data to drive collaboration now that we have so much data. Talk about a little bit about how we're trying to upgrade our skills among our people, and then talk about some new fun projects that we're doing both out west and in other cities. So I was telling you before that we have a certain amount of payer mix. It's all fee for service, sorry, not all of it, it's mostly fee for service with some managed care, but I told you before about half of that was Medicare and Medicaid. Really what we think is going to happen is that the ACOs and the bundle holders and other entities like that are going to take up a larger and larger slice of that pie. And that's really what we're trying to prepare for. So the bundled payment is allowing us to dip our toes into this water. We need to learn. Essentially, we're really doing the bundle to learn and to start getting good at the kind of things that Dr. Bieber's talking about, which has not been our traditional skill set, to be honest. So under the bundle, BPCI, CMS is going to link payments for services through a defined care episode, right? Providers can elect to receive prospective or retrospective bundles, and then you can share in the financial gains if you've achieved savings. There are 4 models to BPCI, which I think you may be familiar with. Model 1, which is pre-acute and hospital. Model 2, which is pre-acute, hospital, inpatient physicians, post-acute, and readmissions. Model 3 is post-acute and readmissions. That's us. And Model 4 is another mixture of that. So we have chosen to go into Model 3. So once people enter into one of our episode triggering locations, they're in the bundle. We're doing Model 3 in the Cleveland Integrated Care Market. Patients are grouped into standardized clinical episodes and included in the demonstration based on their short-term acute care hospital DRG, their diagnostic-related group. So in the end, we are dependent on the short-term acute care hospital having decided, and then that being vetted by CMS and stamped. Yes, that's the DRG that they were in the hospital for. We are dependent on that because they need to be in one of the 7 clinical episodes, CHF, COPD, other respiratory symptoms, et cetera, et cetera. There are multiple DRGs under each of these, but if they come to us from the acute care hospital here in Cleveland and their DRG is outside of those listed from the acute care hospital, they're not in the bundle. So we have to try to figure that out. One of the challenges with that is we don't know the DRG from the acute care hospital until how many months later? 2 months later. 2 months later. So that's tough. So that is part of our analytic strategy that we're trying to understand. We need to be more like an accountable care organization who knows what our population really looks like, the way you have data about your population. We need to have that kind of data because we have to model and predict who's going to be inside of these bundles or not so that we can be actionable. 4 Kindred sites of service can initiate 2 transitional care hospitals. You saw one yesterday, the subacute unit that I think you saw as well, and then the Greens is our other initiating site of service. What's the rationale? So there's many challenges in this model. First of all, we are going to be accountable for care that we don't provide. In fact, we're going to be accountable for a lot of care that we don't provide because as our average length of stay decreases, that means they spend more time outside of our building but still in the bundle. So if they go to get services somewhere, or if they take a vacation to Florida, get admitted to a hospital, or if they drive across town and go see a couple of specialists and then they get admitted to this or that, or someone performs surgery on them before the 60 days is up, nothing to do with us, we are accountable for that. And that's really challenging when you're thinking in your own mind about your own organization, how are you going to collect, process, and act on the data around that? Another reason why I think hospitals were given the reins, I think, at the beginning. Episodes are defined, as I said, by acute care diagnoses. The payment is fee-for-service with then a retrospective reconciliation. The retrospective reconciliation is even behind knowing the DRG. So add another 4 months. So we are in August. We are just now about to find out how we did last Q1. The first quarter of this year, we're about to find out how we did then. The performance and claims data are not available in real time, and the regulatory requirements are not changed. So for example, we could not get CMS to give us waivers for things like the 3-day qualifying stay, et cetera, et cetera. We couldn't get as many waivers as we wanted to try to smooth the transitions between sites of service. The rules are still the rules. So why participate? Because we know that it's going to be more integrated in the future, and we need to create value through reductions in length of stay and getting more patients to the clinically appropriate and cost-effective setting. We just have to do it. So this is how we're going to learn how to do it. We have our initiating sites of service, but of course we have multiple sites of service in the Cleveland area. That includes assisted living, other transitional care centers and SNFs, and our home health, which we're hoping really to leverage to help us manage the bundled patient population. We have a 5-pronged strategy for the BPCI. One is to do things like joint quality and care management committees, which I think you learned about yesterday. We need to be, just like Dr. Bieber was saying, we need to be in conversation regularly with organizations like his and with the Cleveland Clinic, which we already are, because without that communication, it's just siloed. We can't have that. We need better physician collaboration, as we talked about. We have to link our IT systems. We have successfully linked our LTAC, electronic health record, with the Cleveland Clinic. We have tried to do things like that across the country. Unfortunately, it's so labor intensive and time consuming and expensive that there's no way we could do that across the country. That's why we did the HIE, the Health Information Exchange. That's going to eventually be the avenue we're going to have to take. Our transitional care model, which I hope to talk a little bit about, and then our clinical programs that both deliver care and collect outcomes across sites of service for the same what's it called? I put this in here because this is if you have not read this article in the New England Journal, you absolutely must read it. I call it the reality of care management. This was a physician who had a patient with a biliary duct tumor and followed what he did over 80 days, what the doctor did over 80 days. The patient went to 20, I can't remember how many, I think he went to 15 different specialists. He went to 20 appointments, none of them with the PCP. He had 2 procedures performed. The PCP spoke to the family 8 times, spoke to 10 of the attending physicians, and all of these are the touch points. And I looked at this, and part of the article was about how now CMS is going to pay for a little bit of care coordination. How could you not? But to me, I looked at it and I said, this looks like this is post-acute care, right? Patient comes to us, doctor sees them or nurse practitioner sees them. Then they go back to a follow-up visit back at the hospital with a surgeon. Then they go and they get something done with a cardiologist, but they're still in our building. Then we got the lab that's off-site. Then they go back home to home health. Then they get readmitted to the hospital. Everyone's on the phone with everybody. I just thought this was post-acute care in a nutshell. So what are we doing around care management? We're doing what many people are doing. We are trying to deploy people, assets, skilled people to try to smooth transitions across sites of service, to reduce rehospitalizations, and to keep the primary care providers aware of what's going on. That comment that was made about the primary care doctor not knowing, it's so true in America. It's beyond true in America. And that was something we worked on in California when I was there. We sent discharge summaries, we sent notes, I sent little pop-up reminders. Hey, your patient's with us in rehab, your patient's going home this week, your patient needs this. And it was amazing. People actually told me not to do it. Isn't that amazing? People told me, I said, I'm going to send them a little note before the patient leaves to give them the med list, tell them they're going home. I'm going to do it for every patient because I was in an integrated system. So we were connected by EHR. My EHR wasn't in the building, but I could go back to my office and send them a note. People said, don't do it. They're going to be angry that you clutter their inboxes. And I thought, this is madness. And I did it, and people loved it. You know, in our world, post-acute care, as I like to say, is a black box. It's always been a black box For the doctors in the hospital, for the primary care providers, it's a black box. And my goal was always to try to take the lid off the box. I want you to know where your patient is. I want you to know what happened to them. I want you to know what my telephone number is in case they show up in your office in 2 weeks and you wonder what the heck is going on. At least you have my phone number, and I'll answer the phone. So we've done a great job with that, and our primary care doctors really, really like that touch back. So care managers are paired with patients, most at risk, and they do things like they support the follow-up plan, they help with medication management, they communicate with other healthcare providers, they develop a plan for the transition itself, they do a lot of education around what's about to happen to you, right? And a lot of education across the continuum. There is such a voltage drop, and I read the presentation that you submitted yesterday about the neurology program. I really applaud that program. I'm sure you experience this. Patients experience what we call a voltage drop. You know, when I was in San Francisco, I used to say the hospital is a Lexus, and the nursing facility for rehab is a Chevy Volt. I actually used to use another reference, but then people didn't even know the car I was talking about. Because I dated myself. I think I said like a Citroën or something. I said, or, you know, people didn't know what that meant. Or a Hugo. Are there even still Hugos anymore? So patients experience that, and the more you communicate with them and the more you discuss with them the benefits of what they're about to receive, who's going to do it, how often it's going to be, the better things go. And so that's what our care transition managers do a lot of. And they are really, really focused on medication errors. You know, one of the two things that's associated with readmissions to the hospital are things like missed doses of medications and missed meals around the time of transition. So our care managers are really on top of that. That falls beneath the radar of the doctor, right? I mean, what do we expect? We expect better functional improvement, shorter length of stay, reduced readmission rates, and a higher rate of return. How am I doing on time? Do I have 5? Okay, so we've had 107 total care transitions patients who we've followed across sites of service. It turns out that we believe today that only about 66 of them are actually inside the bundle. That's okay. We actually picked up the vast majority of them, which is good. The bundle has been triggered by 66 patients, as I just said. Here's where they triggered. The historic period, which is the look back 2.5 years ago, where CMS is going to set all of our price targets against. Back then, we admitted 28% from LTAC, 22% from subacute, and half at the Greens. Interestingly, fast forward to January of this year, we're now admitting more at the LTAC and less at the Greens. That is complicated for us because now we have to figure out how to blend those things together to see if we're going to hit price targets come the third and fourth quarter. So we're trying to work through that with CMS. Interestingly, things like major joint are dropping compared to our historic period 2.5 years ago. Patients who are triggering the bundle, a real small number are in major joint and even less in hip and femur. I'm not surprised by this personally. I've told the team I'm not surprised by this. I think that's going to continue. But look, sepsis, pneumonia, and other respiratory are just going to climb. And I think the needs of that really complicated patient who may have a lot of breathing treatments, may have a trach, has just had a debridement, those patients are the ones who are going to come our way more and more. There were a lot of readmissions within 60 days. In the look-back period, historically, up to 48% of the patients who would have been in a bundle back in 2009, had there been one by these rules, almost half ended up readmitted within 60 days. Stunning, stunning. These are from in our area with our facilities. That's what would have happened to them. In the early part of this year, we are down to 42%, 28 unique patients, 20 readmissions together. That means that 8 patients had, of course, multiple readmissions within 60 days, right? That number is still too high. And you can see that most of them come from subacute or the Greens, but a lot of them come from home. If I take you to the next slide very quickly, if you look at days in the care transitions program, this is the care transitions program, not the bundle per se, just all of our care transitions people. Days in the care transitions program before they went back to the hospital, because we've been following these people really rigorously, Look at this. A quarter of them, I don't know if you guys can see here, a quarter of them were admitted after 36 days with us. There's no chance these people were in our facilities at this point. Almost, maybe some of them were, but it's that the majority of these people were out at home. They might not be with our home health. We might not have been able to intervene fast enough to get them back to our SNF. Odds are we could have stabilized what happened instead of the emergency room. And so there's a lot of opportunity here. And I'll skip the next one. I just want to tell you about our HIE and the fun projects. I have 2 or 3 more slides, and that's it. So Kindred Healthcare has gone ahead and taken our nursing and rehab centers, which are on one EHR, our LTAC hospitals, which are on another EHR, rehab care, which has its own EHR, and Kindred at Home, home health and hospice, which has its other EHR, and we have wrapped a health information exchange around them. It went live on January 1st. We are populating it with information about patients from all these systems, allergies, problems, medications, vitals, et cetera. All this stuff I'm sure is very familiar to you guys. This is the first opportunity for us to have a population look at all the patients within Kindred's system. This is very exciting. It's preposterously expensive and preposterously complicated. I could not even pretend to explain it to you, but there are 3 incredibly smart people at Kindred who I love talking to who know all about this stuff. But we're not done. We're still missing some things. We struggle to get things like radiology results in there in a usable fashion because half of our radiology results, our lab results, are from other companies. We're not a hospital. It's not in the basement. How do we get that stuff in and then store it? There's an enormous labor involved there. 2 more things. We're trying to use more and more data. Here's an example of something that I've been passionate about. When I was a physician, I kept my own data sets. I collected data at the end of every week on my patients, how many went home, how many went to the hospital, how they did, how many I enrolled in hospice that were appropriate. And I've made it my mission to try to get physician specific data so that we can tell physicians how their patients are doing. Because the physicians in post-acute care in America are often the last to know. In reality, the physicians are not really driving the system. They're ordering and they're taking care of the patient, but they're not driving the system. The nursing home runs itself and the doc comes in and out. And I really think that the physicians are a crucial member of the team, from a leadership perspective, from a systems thinking perspective and knowledge. So for example, for this physician, I can tell them how often they've admitted, discharged, who their population was, how well their patients did in rehab, whether their patients triggered CMS quality measures around falls and stuff. And then for this building, which I blacked out, I can tell you all the physicians and how many they rehospitalized last year, November, December, and year to date. Again, trying to get physicians some data so they can use it in conversations with a ACO, in conversations with another provider. Physicians don't have their own data unless they are employed. More and more of them are employed, but a lot of them are not. And lastly, we are doing an incredible amount of education and training. Here's Dr. Kim from the Cleveland Clinic who came to speak to us. Every year in November, we do a clinical impact symposium where 400 frontline clinicians come to Louisville, Kentucky for 3 days of workshops. Actually, this year we're doing stroke, ironically. Last year we did care transitions and disease management. Here's Dr. Eric Coleman, the guru of rehospitalizations. He's come 3 years in a row. So we are really, really trying to educate our people to keep up with the acuity that we're seeing. And finally, we have to have facilities that people want to come to from a bricks and mortar standpoint. A lot of our divestitures were around facilities that were 50 and 60 years old, where a hospitalized younger patient who needs 2 weeks of rehab will not go. And that is only going to get worse in the future. The boomers are going to have less and less enthusiasm for old, outdated facilities that they remember from their grandmother's days. So what are we doing? We are actually investing quite a lot. We're standing up 4 to 5 new nursing facilities that are rehab predominant. We've worked on an LTAC hospital refurbishment as well. So I'm just going to show you some fun pictures. This is Indianapolis South. It just opened last month. We have, I think, 4 patients there today. We're awaiting state approval to take more. Here is Las Vegas. It's under construction today, down in the west side of town. A lot of our construction now is on the campuses of a hospital. And that really speaks to the need to be partnering. So they're either joint venture or we've agreed to do things together. This is our rendering for a new nursing facility and rehab facility in Phoenix. I thought I died and went to heaven. I've never seen anything quite like that in my life. It looks incredibly chic to me, and I think the community is going to like it. I think the hospital will be behind it more because they'll view it as being more up to date. And that's our spec for Louisville, which is our hometown where we're located. So I just want to say on behalf of our thousands of employees nationwide and our leadership team here in Louisville, who I really did a phenomenal job yesterday and showed you the best, I want to thank you for having me, and I'll take any questions. Thank you. That's good. They know I woke up in Chicago at 4 this morning. They're being merciful.
There's a mic behind you. If you use the mic, because we are recording.
Thank you for sharing your plan.
Thanks.
And we've been involved in some smart home technology development, as well as a product we've developed based on smartphone monitoring of medications. And we know that we've always conceived of a model where a place like Kindred has all the expertise to help with home care as a central facility, and then to surround it with directly, say, within a 3 to 5 mile radius with houses that are essentially extensions of that. Are you thinking along the lines of that direct community relationship, and how do you plan to monitor those folks, given that you have all the infrastructure that would be required to capture that?
That's a great question, and in the interest of brevity, which I probably blew, my apologies, I took out a bunch of slides about that because we're really in our infancy. So when you think we have 157 home health locations around the country, and the home health space seems like the natural place to begin the process of getting the smart technology into the home. So we have had a whole bunch of people come to, you can't imagine, we have everybody coming and showing us their technology. We like all of it. We're not quite ready to actualize it, but we completely, probably in another year or two, believe and are planning on putting things like wearable monitors, patient-activated measurement devices on an episodic basis. So, for example, having something on the wall that they could hang for the next 2 to 3 weeks after they've arrived home, where they could push a button and it would upload all of their data for the day. And then we've seen products, for example, where like a care manager or a nurse will then call them through the device and say, I just got all your data, this is what I saw, I'm forwarding something on to the home health agency and to your doctor, and I'll call you back in an hour, and we'll get a plan together. So we've looked at that, wearable technology, there's a lot of other informatic, analytic technology we're looking at to try to figure out how to combine what we know about the patient and then the data that's going to come from their mobile phone, and kind of merge those together and then figure out how to act on it. I think that what I think from a clinical standpoint, the biggest challenge for us is that because we're sort of not a hospital, although we have hospitals, but we're not sort of an acute care hospital, we're not an academic medical center, let's put it that way. It's hard to imagine, let me back up and say that again. The hardest part for me clinically is the volume of information that I struggle with. Right, we're continuous monitoring, continuous blood pressure monitoring. How are we going to manage that? And a lot of software systems offer us the ability to do that, but we have to figure out how to pay for it. That's the hard part. I think in the end there will be intermediaries between the digital technology in the home and us, and that'll be managed perhaps by people like you who aggregate it, provide the decision support, and then pass the pieces we need on to us. My fear is that there will be massive data looked at, analyzed, and then dumped on us. And that's going to be the hard part. I mean, if there are physicians in the room, I mean, do I need to know the blood pressure 16 times today? No. No. And a lot of the technology is built around that. So we struggle. So after we sort of vetted a lot of the technology, that's what we struggled with. How are we going to integrate this huge volume of stuff into our daily workflow? And we're still trying to fix our home health, which we're still building. But absolutely, there's no question that there will be smartphone type enabled technology in the homes of our patients. I'd like to say by the end of 2015, if that's helpful. Was that too long, Barbara?
Thank you. Thank you. Thank you for your presentation. Want us to think about where's the self-management education for the patient? And if we are expecting them to be successful in the community, how did they know and how are they strengthened to be recognized as part of that healthcare team so that they're not readmitted within the 60 days?
Well, so within our transitional care programs that we stood up in Boston, here, Vegas, Indy, and others, that's a huge focus, is on self-management, especially around the time of transition. So that includes going home. And then the self-management piece continues because our transitional managers visit them in the home and then work on medication logs. One place that we are kind of working on an app actually is we're trying to figure out whether we could have just an app for the transitional care managers to use with the patient so that the agreed upon med list is with the patient in the home or with their son or their daughter or whoever. But there's no question, that's a big piece, is the self-management piece. What we haven't figured out yet how to do is how to broaden the scope so that our transitional care managers don't only have 30 patients or 25 patients. And it's very interesting when you go and you talk with more mature healthcare systems, everyone has gone through this journey, right? Everyone 2 years ago hired transitional care nurses, nurse practitioners, right? Transition managers. And a lot of those systems rapidly downgraded, that's the wrong word, rapidly changed from a nurse practitioner to an RN, and then in terms of their cost, downgraded, not the person, but they changed it to a case manager. And I have now spoken with systems that realized even that was too much. They've transitioned to volunteers calling or recreational therapy teams calling, which is great. And actually some of them have transitioned even to automated things. So an automated call goes in, asks you about your self-management, and if you respond to 2 questions wrong, that triggers a phone call from an RN. So absolutely, patient engagement and self-management, huge. I think that's a very interesting evolving space.
I actually just have a very simple question, and maybe difficult for you to answer. How about the cost? I know different patient has different costs, but your model seems like it's mimicking the hospital, and I don't know how much is the differences in terms of costs.
In terms of knowing the cost, or?
In terms of the per patient cost.
The per patient cost.
Just say like cardiac surgery patient.
Right.
Or the kidney transplant patient. How much is the cost in the hospital versus in the Kindred?
So here's I guess a dirty little secret. In reality, our systems up until today were not really set up to tell you the cost of the patient based on those groupings. We washed all of our costs into our accounting software. So we knew the prices of things that we paid for, but not actually all the costs. And some of that was defensive, right? A lot of organizations didn't want to share what the real cost was with anybody, lest someone else find out. And we have to, part of what we're doing now is unwinding that, because we need to be able to say to Aetna Health, United, the ACO, whoever, this is how much it costs for us to manage these DRGs over a 6-month, over a 90-day episode, or how about a 30, 60, or 90 episode, take your pick. This is our cost, these are our results. That's what all of the care management technology is about doing. Yeah, we have to be there. Otherwise we can't play. Yes.
I found myself worrying about the 140 hospitals that you sold off.
Yes, you're not alone.
And, you know, ostensibly because they were standalones or not an integrated. So is it like, do you foresee the need for a different type of a system in rural areas? Or say I go even further, your model seems to be built somewhat on vertical integration,
Yes.
even co-location. Is that something you would recommend to our guests from Taiwan?
So I personally worry about rural facilities a lot. From someone who's responsible for ensuring that there's physician coverage in those places, I worry about it even more. There's often only, I guess I have to wake up and catch my plane. Not sure how that happened, I'm sorry about that. So I worry about that a lot. There's a dearth of providers, there's a dearth of this level of thinking. All of the facilities that we, the skilled nursing facilities that we dispositioned were picked up by local providers and regional providers. I think from our perspective, we felt that we need to be good at the systems, like you were talking about, in the integrated markets first. I think eventually a lot of that learning will reach the rural areas, but you can't, it's hard to build it from the rural area up. And I think between the ages of the buildings, and there were other factors around leases and stuff, but the ages of the buildings and the fact that we need to pour so much resources into this, we needed to do it in places where there was critical mass. But I think eventually that once these systems are mature, that, and everyone else's systems are kind of all growing up together, right? Eventually the physicians, eventually physician organizations that are trying to grow are going to have to figure out how to solve the problem of rural medicine also. I mean, you can't just be we're eventually going to have 100% employed physicians in this country, and you can't have the employers say, we don't care about Wind River, Montana. That's not appropriate. So as those systems grow and ours grow, I think eventually they'll push out into the rural areas, but it's a real challenge. I think about it a lot. It bothers me a lot that they can't access the kinds of things that are being developed in centers like this. So, well said.
So Mark, thanks for a wonderful presentation. I think, from 1983 and we implement the DRG system, and then we see the whole change of the landscape of post-acute care and long-term care. And your experience kind of take us, go through the past 20 years, what we have learned, and then move into a very different model, which is a very accountable model. So thank you for providing us with some of the visions. And my question is, Kindred is private and owned, and I think New York Stock Exchange company, right?
Publicly traded, yes.
And in general, in the healthcare field, we don't like private industry to get in. How you see a private industry? What is the value a private industry can bring into the landscape of the whole continual care?
I think that, it's tough. I asked myself that question, when I left San Francisco to come join and participate. And I think that the thing, I remember a fateful conversation I had with the CEO or the COO, where I said, and I was on Epic in the hospital. Kaiser had just spent $2 billion to put all of their hospitals and clinics onto the Epic EHR, which I lived and breathed and loved. And I remember I said to him, I said, do you promise me that if I come there, that within 3 years or 4 years, you're going to have every one of your nursing centers be electronic, with electronic medical records? And they said, Mark, we have earmarked the money and we're going to do it. And we're doing it. And I said to myself, that's not something, those kinds of things, taking a risk in a bundled payment. We've now just stood up an accountable care organization, actually. So Kindred is now a co-owner with a physician group of an accountable care organization in Las Vegas called the Silver State ACO. Someone had to write a check for that to try to see if there's room for the post-acute long-term people at the table with the docs and the hospital systems and everybody else. And I think that the private groups with some scale can actually really do very innovative things on a broad scale. And you can't get that. I mean, I was at Kaiser Permanente, and they just wanted to discharge patients to SNFs. They weren't going to actually invest in anything. And I kept going to them with all these plans. We should do this, we should do that. And they weren't just going to do it. So I think there's a role. Interestingly, being at a publicly traded company, I'll reflect for a second, I actually kind of like it because we have to be very transparent about a lot of things that a lot of other people in our space are not transparent about. I mean, the reality is you don't know how much money half of these other companies that we're up against made because they don't have to tell you. But we have to tell you. We have to tell the government, we have to we have to do all these things. And I actually kind of like it. It lends a window of transparency on us that I enjoy, and I think that becomes cultural. We have shareholders, we have to take care of them. We have patients, we have to take care of them. So I think there's a place for it. And I will say this, for someone who was in academia and then holy cow, do we do things quickly? I mean, we do things quickly. And it is stunning to me how quickly the for-profit world can get something done. I've never seen things done that quickly in my life. I was going to just plan a committee meeting. It was already going to be done in a month. I thought we should have a meeting. So very interesting. So I think there's a role for that kind of nimbleness and those resources. I hope that helps. So, thank you, everybody. Appreciate it. Thank you.